So good afternoon, everyone. So as I've been asked to speak on rehabilitation in brain injury, as you understand, it's a huge topic, and try to minimize it as much as possible so that it's beneficial for your exams. So a few slides, and I'm sure you will get to know something about an overview of rehab in brain injury. Very quickly, what is brain injury? Could be from an injury and a non-traumatic one. So as you understand, it could be a closed brain injury or even an open one. Closed, it's where you have the skull is intact. If it is an open one, it is either the skull is penetrated or there might be a fracture. Now, non-traumatic causes: stroke, tumor, hypoxia, infection, etc. So this is a slide which shows the incidence and prevalence of the causes and the common deficits that we suffer, that the patients who suffer from brain injury, and that's an Indian slide. So as you understand, the largest group is formed by the injury, followed by stroke, and the rest follows. If you look at the common deficits after brain injury, the most common are the motor deficits, followed by cognitive impairments. These are always there, but I think one of the most important aspect of brain injury is cognitive. So now, moving on to the signs and symptoms, there could be neurological, cognitive and behavioral, motor sensory, and the posturing ones. So what are actually the signs and symptoms? So it could be headache, dizziness, nausea, vomiting, loss of consciousness, seizures. But this is something which we really need to keep in mind, because this is unless and until mind and the body works together, even if you work too much on the body, we don't get the good result and the good outcome. So these are always there. But again, I always keep on harping on the cognitive issues of brain injury. Posturing, as you all understand, decorticate and decerebrate. Sometimes it comes on your exams as well. So you need to know how it works and what are the postures that actually happens in a decorticate or a decerebrate posturing. So now, why rehab is so crucial in brain injury? If you look at these four aspects, so it prevents the disability, it improves the recovery, restores independence, probably the most important one, and for the family, it reduces the burden, and obviously on the economy, it reduces the financial impact as well. So overall, what we look at in rehab is basically improving the quality of life. Now, these things I have already discussed before. So these are the impacts of brain injury. Again, just refreshing your memory: physical, cognitive, emotional, behavioral, social and vocational challenges. So what could be the outcome of a head injury? The patient might not survive. He or she could run through a vegetative state. These three are the disabilities which the patient can, these two are the disabilities which the patient runs through, and a good recovery. That is what we want at the end of the day. It could be a natural recovery, but always augmented and helped through rehabilitation. Now, these are things which probably you all need to know, and these are the assessment tools, very important for your exams. More than that, you really need to know as to how to assess a patient with head injury. So, I don't think I need to run through this. It's mild, 13 to 15, moderate, 9 to 12, and severe, it is 3 to 8. So these are the classifications you need to keep in mind. I'm sure everyone has heard about RLA scaling. I am very happy when the patient is in the third or the fourth level, because that is the level where we feel confident that this patient is and will come out of the problematic state. So that now to reach this state, we definitely have to run through this patient from the very first day. So the most important part about rehabilitation in a brain injury is not when the patient is improving. We have to be proactive in starting the rehab from the acute phase, which includes patients even on ventilators. Now, this is regarding the memory part, the PTA. I won't run through all these, but the important lines which I really need to read out to you. So this is basically a Westmead post-traumatic amnesia scale. These 3 lines are very important. PTA may be deemed to be over on the first of 3 consecutive days of a recall of 12. When a patient scores 12 out of 12, the picture cards must be changed and the date of change noted. PTA may be deemed to be over on the first day of a recall of 12 for those who have been in PTA for more than 4 weeks. So these are the 3 lines which you really need to keep in mind when you are assessing the amnesia scale. This is so initially it was how good or bad the patient is. Here it is how much the outcome the patient has achieved. So this is the Glasgow outcome scale. So again, it is from the patient not surviving to the patient having a very good recovery. So this brings us to what are the neurological approaches in brain injury rehabilitation. As you can see, nothing is demarcated. All these are actually overlapping. So there is no single treatment approach which is specific to brain injury rehabilitation. It's basically a conglomeration of all the approaches. Now, quickly I'll just run through these because you do not need to know about the process, but you need to know about the principles. So what is motor relearning program? Again, the basis of everything lies in repetitive, task-oriented approach. It's not just once a day or half a day for 2 to 3 minutes. It has to be how much the patient can take, attention span, but at the end of the day, it is a task-specific, repetitive approach. So what is the goal? It is motor control and improving independence. Roots approach, a lot of things are mentioned out here, but it's basically sensory stimuli. So slow brushes, icing, and all the techniques that the therapists use. But for us, it is very simple. Keep on doing it repetitively and as a proper task. Again, neurodevelopmental, this is the Bobath approach. Important things, focuses on posture and movement re-education. Again, it's based on the improvement of neuroplasticity, and if you again note here, it is task-oriented and repetitive. So all the approaches which I have just shown you here is based on repetitive, task-oriented approach. And the goal, only one goal, to improve the functional independence and quality of life. PNF, again the same thing, but the important thing here is, if you look at the first, this one is very important. Spiral diagonal movements, because here what the principle says is initially when the patient doesn't have any tone, you are actually trying to improve the tone. And if you are wrong in doing the approach, there is chance that this might lead to abnormal synergies. So you need to be very careful and you need to supervise the program even if the therapist is doing their job. So, just an overview. I'm not getting into the details of this. If you look here, all these show only one thing. It is a task-oriented, repetitive approach. Why I'm just trying to reiterate this, because that is the basic principle of these approaches. So, coming to the team. Once these people finish off their job, it's our job. And we as the PMR specialist we are basically the Zubin Mehta of the orchestra. If we run this show properly, there is a good outcome. If we don't, it's just gone. So these are the team members. Now, how do we approach this rehabilitation in a patient who has suffered a brain injury? It has to start from the acute phase. You need to have an idea as to how to rehabilitate a patient from the very first day when the patient is admitted. You need to know how a ventilator works. You need to know when to wean off the patient of a ventilator, because even if there is an intensivist to help you out, you have to call the shots. So for that, you need to learn, you need to experience, you need to work on a proper ward where acute neurorehab is practiced. Why is acute approach so important? If you look here, this is what the hospital wants. Quick in and out, so that they can earn a few bucks from surgeries. For the patient, it is improved functional status. So, start rehab from the ITU. Step down, post-acute, it's for traumatic brain injuries as well. So, what does Cochrane say? There is good evidence showing benefit from early intensive rehabilitation. So, these are all post-acute, down from the ITU onto the ward. And it's a smooth pathway, smooth transition from the acute phase onto the ward and at home through the outpatients. So why early rehabilitation? And what is early rehabilitation? It's actually in the emergency, less than 40 to 72 hours, or as soon as the patient is hemodynamically stable. What are the components? Optimization of medical management. There are still, it was there, it is there, and it will be there, that we will always have a tussle with the therapists. But we have to hold this thing very close to our heart, because this is the card that we have to play. We have to optimize the medical management, not depend on the neurologists or the neurosurgeons to manage our patients. We have to be definitely good in managing patients, our patients having medical complications. Care of tubes, be it a nasal tube, be it a PEG tube, be it a catheter, be it whatever. Positioning, chest physio, I don't think I need to emphasize on these. Early orthosis to maintain the muscle length, early detection of neglect and apraxia, because these are very important, these are quite important complications of brain injury. We have to pick these things up as early as possible, because definitely these will interfere with your rehabilitation. Speech and swallowing, and assessment and cognitive by a rehab psychologist. So what are the advantages? Advantages for us, advantages for the hospital, advantages for the patient. So for us, as early as we can take the patient out of the mechanical ventilation and ITU, our anxiety comes down, because our biggest anxiety is these patients on the ITU might develop an infection, which will become very difficult for us to handle. So as early as possible, start early rehab, get them out of the ITU so that these patients can start off with their inpatient rehabilitation. So once the patient starts off with their inpatient rehabilitation early, the hospital is happy because the patients can be discharged early. So once the patients are discharged early, the hospital can get in patients for surgery. So hospital is happy, we are happy, at the end the patient is also happy because there is increased functional independence at discharge. Now, there was a study long back which showed that appropriateness of elective referrals to physiatry and physiotherapy from different acute clinical services. It has been found that 47 of patients referred for physiotherapy alone actually needed physiatric consultation. So these are very important things. We keep on fighting with them, but the problem is that we have to understand how important we are in this whole system. Now, what is our role? So at the end of the day, question will come, what is our role? Very important role. First of all, as I mentioned, we need to know the neuropharmacological management. We cannot just rely on our colleagues to come and help us with writing a baclofen or treating a patient with infection. It's timely discharge and follow-up. Probably the most important, I think, difference between us and the Western world is there is a discharge planning manager. So the patient enters, probably in a joking way, more than the doctors, the discharge managers are more involved because they need to discharge the patient as early as possible. Now, liaison with the acute care colleagues, we have to keep them on board because, as you understand, rehab is a feeder-dependent unit. We also need a good relationship with our colleagues and get them in to save yourself from a medico-legal problem as early as possible, if any complications arise. So, planning a proper rehab program, and you have to execute your ideas as the team leader. As a caretaker of the department, as the team leader, you have to execute your ideas. So that brings us to what are the goals? Very simple goals. Restores independence, maximize functional recovery, improve quality of life, prevent secondary complications as early as possible. Very simple 4 lines, but very difficult to achieve. So, this is an important graph which shows the first 3 months after injury. Look at the peak of improvement. Slowly after that, and these are all Cochrane-based evidences. After 3 to 4 months, it starts slowing down, and over a period of time, the improvement plateaus. Now, there is a school of thought which says that the improvement in brain injury happens in a step ladder pattern. That is why it is so important to have the patient with you. When you know that the patient has reached a plateau, it doesn't mean that the patient won't improve any further. Probably there is a time when you can discharge, get them back later for further rehab when there is a certain change in their cognitive or physical status. So, step ladder pattern, you just need to know when to discharge and readmit if needed. Now, physical rehab, I don't think I need to get into these. So, it's physiotherapy, it's occupational therapy, it is orthotics, prosthetics, it is high-tech, cognitive, speech, swallowing, all the domains of rehab. And for me again, this is probably the most important, the psychological part. Now once you finish these things, you need to get the patient into his or her near normal status. There you need a medical social worker as well. So at the end of the day, you need to have this full team, and the full team has to be run by a person who is pretty aware of what he or she is dealing with. Now, why I have kept this as a separate slide? Because this is the most important thing while a patient is admitted in the acute setup. You need to monitor, you need to manage, and you need to prevent any cardiopulmonary complications, because that is where the duration of stay increases. If there are recurrent infections, I can just share a couple of short things with you. When I joined my department initially, that was almost 11 years back, in the ITU, when we thought of getting masters in cardiopulmonary physiotherapists, now we have 6 at that time we didn't have anyone. The consultants were of the opinion, why do we need a person who is trained in cardiopulmonary physiotherapy? Why can't our intensivists do it? That was 11 years back. And now, if a single patient is non-seen in a day, those consultants complain, why are they not being seen? So this is the scenario, how it has changed. I still remember initially when I joined, that when I was seeing my referrals, I just wrote there, the patient to be sent to OT. That patient was kept NPM from midnight because the nursing staff thought that he'll be sent for operation the next morning. That time we never had any occupational therapists, and now we have 6 occupational therapists, which is a luxury in a unispecialty hospital and in a department. So this is how things have changed. But again, things don't happen overnight. It happens only when you can show the results. So this is how a proper cardiopulmonary rehab happens in the ITU. Again, those orthosis and the orthosis. Now again, these are technological interventions. I don't think I need to get into these, but you really need to know about these because there might be questions asked in your advanced rehab paper. So these are things from our department. Why I'm trying to show this is, at the end of the day, rehab, the cornerstone of rehabilitation is still conventional method. We just add technology to augment the improvement. So unless and until conventional marries properly with technology, I don't think you get the proper outcome. So here we can see, like, starting from tele-rehabs to virtual rehabs, and these are all the apps which we have made in our department. This includes the cognitive games as well. You have the proper virtual rehab machine. You have the hand robotics, and actually what I have started recently, just a month ago, we are using Google glasses for patients on the ITU who have a bit of cognition, so that they have the games put onto their Google glasses, so that they can start off with the rehab even from the ITU setup. Very easy things to run through, but there are challenges, lot of challenges. First of all is the patient adherence and motivation. Financial constraints, lack of specialized centers in some regions, and obviously it's a long recovery period. So I always tell my patients, relatives, that you have to be patient with your patient, because unless and until you do that, you just keep on bothering us, which actually doesn't help in the treatment of the patients. So we have to be very clear with our counseling that this is not just a cough and a cold, that we will just give some cough syrups or paracetamol. You need to understand the reason behind while the patient is with us for so long, and you need to be patient to get a proper outcome. So just a few examples as to how rehabilitation helps. So as you can see, this is when the patient was admitted, had both cervical injury as well as traumatic brain injury, run through almost 3 months, put on a halo as well. Now this is the guy back to, he was from, I think from Jharkhand somewhere. Anyway, so now he is back, he is working, and he is back to his work. So this is the first day when the patient was admitted.
इसमें छोट है पीछे पीठ में देखो पीठ ये वाला पैर काम नहीं कर रहा ना आएगा ना तो ठीक लगेगा
So this is just a few days back. So this patient was with us for almost 3 months. I think he has definitely made functional gains. So this is a kid, freak accident, fell from a roof, lost her father to COVID as well while she was being rehabilitated with us. Went through the whole process of rehabilitation, and now she is back to her school. She's in class 2, and she's definitely left with a bit of dystonic posturing, but overall she's functional. So these are all sensory techniques. So here is a physio, here is an occupational therapist. So again, that actually I made a small film with her as well, and I sent it to this Turi Film Festival, and we secured the first position in that. So anyways, now this is a patient from Bhutan, delivered a twin, was probably declared dead in Bhutan, and they asked her to take her home, but she was airlifted from Bhutan, brought down to our institute. Didn't undergo any surgical intervention. She had a pulmonary, brain hemorrhage, but that didn't need any surgical intervention. So smoothly transitioned under us. Lot of struggle with her. She was with us for almost 5 months, and at the end of the day, I must tell you, Bhutanese wine is fantastic. So the day she left, the family actually gifted me that, and you can try it sometime. Now, this is the day before she left. Dancing to a Bollywood tune. And the best part is that this lady went home after 5 months. She got to see her twins, and this is what we earn at the end of the day. Again, a female had a subarachnoid hemorrhage, was in coma for almost 4 months, went through the rehab process and came out of coma. Now she's almost back to her near normal state. This guy, this from 2016. So he was actually from Germany, flown down. He was actually a forklift hit his head. He had a spinal cord injury as well as a head injury. So again, properly rehabbed with the full team, and you can see the outcome here as well. So the outcomes, again, improved independence, better community participation, enhanced quality of life, and the most important part, reduced caregiver burden. So conclusion, rehab is a lifelong, team-based journey. It should be early, it should be intensive, and it should be tailor-made to the patient's need for the best outcomes. These are all Cochrane-based rehab framework. So if you notice, it's a task-specific and intensity matters. So that is what I was trying to harp on. So this is what you earn at the end of the day. Thank you.
Sir, like initially the patients after traumatic. Yeah. Good afternoon, everyone. I'm Dr. Vishwas. I'm JR in PMR from AIMS New Delhi. Sir, initially the patient has cognitive dysfunction, or if they are just coming out of the coma. During that period of time, it will be very difficult for them to follow the instructions, like for any therapy or any exercises. So during that time, even like you said that even in IT you are planning for, or you are giving people, those who have like slight cognition, they are using Google Lens. But how much like cognition impairment will affect, and then how you tune it to your therapy for them to understand the commands or follow the particular portions of the rehab plan?
You have to understand one thing, that every patient is not the same. So there will be patients who are absolutely conked. They have no idea about what is going around in the environment. You cannot just stick a glass onto their eyes and ask them to do the rehab. So those are patients whom you have to start on coma stimulation program. I'm not sure whether you have heard about it, but that is the cornerstone of improving cognition in a patient who is severely comatose. So again, it's a process. There are principles on which coma stimulation program works. So again, every patient doesn't improve from it, but we have to give it at least 2 to 3 weeks. And that's again a teamwork which is led by an occupational therapist, physio's work, and we have to see the subtle changes in their cognition over a period of time. It's not that you just keep on doing therapy for a patient who is in coma stage for half an hour to 45 minutes. It's very short but frequent durations, intensities. You have to keep doing those therapies. Now, once the patient is, the thing which I mentioned about the glass, I think you might have missed out on what I told. I told for patients who have a bit of cognition, to improve their cognition further and also to work on their physical and the functional part. So these glasses, actually we have incorporated a number of games, which has both the physical games, the functional games and the cognitive games as well. So it is very important to assess the patient on a regular basis, not for patients who are improving, but for patients whom we need that improvement. So we have to assess on a regular basis, we have to keep working with the team, and at the end of the day, we have to make our rehab goals according to the patient's need. Now, for an IT patient, we will definitely not ask him to be trained in how to use the hut. The same goes for a patient, for a villager as well. So we need to understand what the felt needs of the patient are. If we are not able to get it out from the patient, we have to get it out from the relative. So tailor making a goal is probably the most important part of rehab.
If you are asking about cognitive rehabilitation, just to add what Dr. Suparna has said, actually it depends on the phase, in which phase the patient is, and actually what assessment skills you are using to assess the cognitive impairment. Like at our places, we use Edinburgh Cognitive Impairment Scale, or this MMSC, a shorter version of this Edinburgh Cognitive Scale. And since we don't have this Google Lenses with us, so we can also do some innovative things like letter cancellation, block designing, matchstick designing, something like that. And later on, this comes the virtual reality and augmented reality. It's not in minutes or day things, in the phasic manner, and in which phase your patient is, and what you have assessed, what is the cognitive impairment, and what difficulty the patient is facing. Then you can accordingly plan cognitive rehabilitation. Just to add what Suparna has said.
I'm Dr. Chandni from St. John's Medical College. I was just curious to know what are the neurostimulant drugs you use at your setup?
Actually, for me, these are all poisons. So let me be very clear. We always want to keep the patient chemically unlocked. So that is very important. We only use neurostimulants like so if I get a couple of minutes, I can just explain what we did for that Bhutanese patient. So very interesting. When the patient was being managed under the neurosurgical unit, she was just like a log of wood. So the psychiatrists were brought in to assess what exactly is going on. So that patient was actually assessed and diagnosed to be in a catatonic stage. And they started lorazepam. Initially IV, the dose went up to 18 milligrams a day, which is quite a heavy dose of lorazepam. But again, the patient showed no improvement. Rather, whatever the things we were seeing in terms of her pupillary reaction, even that was gone. So they had to wean her off the lorazepam. Then the neurosurgeons asked us to take over the patient. So what I'm sure Dr. Venu might remember this case. Actually, when I was working in Australia, there was in Geelong, there was a patient, 35-year-old female, head injury, mother of 3 kids, doting husband, exceptionally good family. Now, she was actually the same as this patient. Why I am saying? Because there's a drug called zolpidem. If you have heard about zolpidem is basically a sleeping drug. It will just put you to sleep. But it paradoxically works as a neurostimulant. I'm not going into the mechanism right now, but I have seen with my own eyes that zolpidem dose of 10 milligrams for a few hours that actually stimulated that patient. The same thing I tried with this Bhutanese, and like it's not that you try it blanketly with everyone and it works. It doesn't work. But somehow this lady responded to it, and you have seen the outcome. I'm not saying that it's just because of the zolpidem, but it also helped. So now, getting to your question, it's not all the neurostimulants work. You can give amantadine, you can give methylphenidate, you can give everything. But unless and until you assess the patient properly and start off with a small dose to see if there is any improvement in the status, that is very important, and that should be your approach.